Ladies and gentlemen, I'm Dr. Yang. I'm from Changhua Christian Hospital. I'm a cardiologist. Today, my topic will focus on diabetes and the cardiovascular complication. In Taiwan, we always see this kind of food in diabetes patient, but we always call it DM food, DM food. Is it true? I think the diabetes is maybe the origin, but the major factors to make this result. The first one is peripheral artery disease. The second is diabetes neuropathy. So we have to control the diabetes. It's very important. The second complication of the diabetes is stroke. If you are suffer from the diabetes, you can suffer from the systemic inflammation, arterial stiffness, or endothelial dysfunction. The systemic inflammation and the arterial stiffness will induce the atherosclerosis, and the endothelial dysfunction maybe induce some thrombus or inflammation. All of them will cause the stroke. This is diabetes and the acute myocardial infarction relationship. The data from a Danish registry. This line means no diabetes and no prior myocardial infarction. This blue line is very lower. And the second line is prior myocardial infarction. The orange line is diabetes. So we can see these two lines in men or in women, they are overlap. So there is one concept. We sometimes said that diabetes equals to myocardial infarction. I think this is a very important study to reveal this concept. So if you are suffer from a diabetes and a prior myocardial infarction, the risk is more higher than previous three conditions. So for the peripheral artery disease, we can see the diabetes and the smoking. These two factors is very important for the peripheral artery disease. If you have diabetes or if you're a smoker, I think maybe you will suffer from the peripheral artery disease in the future. So the diabetes complication, just like the cardiovascular disease, including the cardiovascular disease, just like the coronary artery disease, cerebral artery disease, and the peripheral artery disease. And sometimes they are overlap. Maybe someone suffer from the stroke, and he also suffer from the coronary artery disease or myocardial infarction. So how to treat the diabetes? This is the figure I very like because it shows all the mechanism of the medicine to treat the diabetes, just like the metformin, DPP-4 inhibitor, GLP-1 receptor agonist. In recent 5 years, the topic is GLP-1 and the SGLT2 inhibitor because it is different the mechanism from the previous medicine. This table is I make this table to show all of you to see the benefit or the risk of all the medicine, just like metformin, sulfonylurea, DPP-4 inhibitor. The red color means the risk, just like if your eGFR less than 30, don't use the metformin. And just like this one, hypoglycemia risk is higher in the sulfonylurea group. So the DPP-4, I think, is very safe medicine because all the side effect is almost neutral. The heart medicine, just like the SGLT2 inhibitor or GLP-1 agonist. The SGLT2 inhibitor, maybe in the DKD, diabetes kidney disease, possible benefit. And heart failure may be benefit. And the CVD may be benefit for this three group. GLP-1 we can see maybe in the heart failure or the cardiovascular benefit. So I think these two medicines will be listed in the guideline in the future. How about the insulin? Insulin, the most common side effect of insulin is hypoglycemia and body weight gain. It also increases the congestive heart failure. So if you want to use the insulin, you have to control these three risks. In the previous study, we know the empagliflozin and the dapagliflozin, they used in the diabetes. They see the cardiovascular event decrease. They also see the heart failure improve. So the doctors, they use the SGLT2 inhibitor in congestive heart failure patient. The first study is DAPA heart failure. The second study is EMPEROR-reduced heart failure. These two clinical trials published on the NEJM. The EMPEROR-reduced, we can see the primary outcome is to reduce the 25% risk and about the hospitalization of heart failure. It will reduce the risk 30%. It is similar in the DAPA heart failure. We can see the primary outcome, the CVDs, heart failure hospitalization, or urgent heart failure visit, is reduce the risk about 26%. So the ADA Guideline in 2020, it suggests if you have CVD, you use the GLP-1 agonist or SGLT2 inhibitor. If you have the history of the heart failure or chronic kidney disease, you can try to use the SGLT2 inhibitor. If you want to control your body weight in diabetes patient, you can try to use the GLP-1 agonist or SGLT2 inhibitor. So how to treat after control the diabetes? How to treat the cardiovascular complication? In the stroke, we don't have nothing to do because for a stroke patient, control the risk factor is the most important. Maybe we have to stop smoking or eat better or reduce the blood sugar or increase your daily activity. And you have to consider control your body weight. Otherwise, you can exercise 3 minutes, 5 to 7 days a week, and it will improve your memory. How about the coronary artery disease? We call it CAD. In Taiwan, coronary angiography and intervention are very common. It's popular? I don't know, because our ex-president, he received the intervention and used the stent for the coronary artery disease. So the people in Taiwan always know what is stent because they know the coronary artery disease can use the stent to make the vessel diameter bigger. But if a patient with stable CAD, CAD means coronary artery disease. What is stable CAD? Stable CAD means if you can use the medicine to control your symptoms like the angina, chest tightness, it means stable CAD. There are two big clinical trials to reveal the effective if we use the medication therapy or intervention, which one is better? The first one is Courage trial. The second is ischemia study. The Courage trial, they see that there are 4 figures here. The conclusion is no difference between the medical therapy and the intervention group. So if you are a stable CAD patient, do you want to receive the intervention? I'm not sure, because this trial tells us no difference between the medical therapy and the intervention. So if you can use the medicine to control your symptoms, I think you can use medication only. But if you have moderate to over severe ischemia symptoms and you can control it by the medicine, ischemia trial told us There are no differences between medical therapy and the intervention. The conclusion is similar to courage study. So according to these two studies, I think in stable CAD patient, maybe you can use the medical therapy only. How about the peripheral artery disease? Peripheral artery disease, we always use the secondary prevention. Because if you find the peripheral artery disease, it always means you are suffering from the claudication or the chronic wound or healing. So the secondary prevention, we can use antiplatelet, just like aspirin or clopidogrel, and we can try to use the ACI or statin to control your lipid. So you can discuss with your doctor what kind of the antiplatelet you have to use, or if your blood pressure is higher, you can try to use the antihypertensive treatment. If your lipid, just like the LDL, is higher, you can try to use the lipid lowering agent, just like the statin. Adherence is very important for everybody because if you match, just like the four factors, the, the four factors including the antiplatelet agent, statin, ACI, and quit smoking, you can do four. The blue line means you can match the four factors. The orange line means you didn't match the four factors. If you match the four factors, your cardiovascular event and the liver event is lower. So good adherence and good compliance will lower the CV event and the liver event. So my conclusion is diabetes is a risk factor of cardiovascular disease. Control diabetes with oral anti-diabetes medicine or injection medicine, just like the GLP-1 agonist or insulin, is very important. For cardiovascular complication, risk factor control is very important. Just like the coronary artery disease, we have to use the medication first. Maybe we can use the antiplatelet like the aspirin or clopidogrel. Intervention for acute myocardial infarction, not for stable CAD. Stroke, maybe we can use the thrombolytic or thrombectomy in acute phase. But in chronic phase, we have to use the rehabilitation for quality of life improvement. For peripheral artery disease, wound care and the intervention will be considered. But these three complications is not the most important because we have to control the diabetes first. Thank you for your attention.